Here we are back for part two, adventures in using a different program for once. I accidentally hit the home screen and I'm borrowing someone's iPad and I don't want to have to, I didn't know what their code was, but here we are. So what we were talking about the importance of hemoglobin. So on the red blood cell surface, we have all these hemoglobin molecules, and that's what oxygen can bind to. Oxygen is not able to bind directly to the red blood cell surface, but oxygen can bind to hemoglobin. Okay, and then lastly I mentioned that, just laughing at myself, lastly I mentioned that hemoglobin is going to transport mostly oxygen, but it does transport a small amount of carbon dioxide. Okay. So these erythrocytes, it's very important that we have enough of them. So you probably, I think we talked about this in the bone chapter. As a matter of fact, I know we did. Now we're just reviewing. Where are these red blood cells produced? The red bone marrow. Think back to the bone chapter. Red bone marrow is found in the epiphysis of our long bones. The red bone marrow is in the spongy bone. Okay. So let's talk about this feedback loop. So what happens is our body has to constantly monitor how much oxygen there is in the blood. It's such an important, vital thing to our cells that we don't want a sudden drop in oxygen levels. So what happens is we have certain sensors in our body that their only job is to sense blood oxygen. That way, if that receptor senses a drop in blood oxygen, that receptor will quick talk to the kidneys. It'll tell the kidneys to release a hormone called erythropoietin. You should know that hormone. Short version of that is EPO. Maybe you've heard of this, EPO. Tour de France cyclists have been known to blood dope with it, thinking if I can inject more of a hormone I naturally have, but if I can inject more of it, maybe I can produce more red blood cells, and maybe I can transport more oxygen, and maybe I can bike longer, faster. But it's a natural hormone, right? And it's released from the kidney, and that hormone, erythropoietin, will go to the epiphysis or end of the bone. And EPO will tell the red bone marrow to produce more red blood cells, and then those newly produced red blood cells go back into the blood to bring our blood oxygen levels back to normal. You should know where blood cell production happens in the bone. You should know what hormone triggers it, erythropoietin, and you should know where that hormone is produced, the kidney. You can read about how many blood cells we are producing in a very short period of time. Suffice to say, a lot, but I'm not going to ask you that number. Okay, just because this is kind of common, I'll talk about a couple disorders. So if the body, for whatever reason, is not able to produce enough red blood cells, it could result in anemia. Anemia is a condition where there are too few red blood cells. And because the red blood cells transport oxygen, therefore, in this condition, not as much oxygen can be delivered, and the symptoms of anemia would be things like lethargy, or kind of being fatigued and slower in processing and weakness. A second example that is not in red, so you don't need to know it, but in case you're wondering, there's also a sickle cell anemia, where not only do we have a shortage of red blood cells, but some of the red blood cells that we have are irregularly shaped in the shape of like a crescent moon or a sickle. And when that shape is altered, the red blood cell can no longer do its job. But that's not in red, so you don't need to know it. All right, we talked about red blood cells or erythrocytes. Let's talk about white blood cells or leukocytes. Make sure that you know that both of these refer to a white blood cell. White blood cells, another name is leukocyte. they are structured very differently. The white blood cells are larger. Here's one. Here's one. They're larger, and they do contain a nucleus. They're also produced in the red bone marrow, along with the red blood cells. And their function is in immunity. These are the white blood cells that help us to fight off foreign agents. They do that through a process called phagocytosis, which is basically cell eating. We'll discuss that more later. But for now, the basic structure. White blood cells are larger, and they do contain a nucleus or nuclei. They're also made in the red bone marrow along with the red blood cells. And they will be found in a lower quantity. As you can see in this microscope slide view, many, many, many more red blood cells, fewer white blood cells. Now, if a person was sick, if they were actively fighting an illness, our white blood cell count would probably go up a little bit. It's a condition called leukocytosis, where we have more than usual. But if it's fighting an infection, that means that our immune system is working. So for a short period of time, it's not really a bad thing. All right. See, now we're getting even more specific. That gets me excited. So there are 5 specific types of white blood cells. They're not all the same. All the red blood cells are the same, but not all the white blood cells are the same. Of the 5, which are neutrophils, lymphocytes, basophils, eosinophils, and monocytes, I'm only asking you to know 2. And I'm asking you to know the 2 that are most common. The white blood cell that we have the most of is something called a neutrophil. Picture at the top, it tends to have a segmented nucleus. It is granular. Okay. This is most abundant, and this is our generic pathogen fighter. So it can really fight almost against any kind of bacteria. Neutrophils, most common type of white blood cell, and they can really just fight off pretty much everything. They're kind of our generic fighter. But then we have our lymphocytes. These are second most abundant, and what's unique about the lymphocytes is that they have specificity. They will be targeted only to fight a specific thing. So a certain lymphocyte may only be able to attack and kill a certain bacteria. When I teach this in the immune system, which we'll get to, I talk about it as an example of people in the military. Whereas the general troops on the ground would be the neutrophils, and the general troops on the ground might try and kill anybody in their path, versus the lymphocytes are more highly specialized. So a sniper might be an example of a lymphocyte, where it's more highly specialized, and it is functioning to target a specific thing. All right. Just as I talked about a disorder with red blood cells, which was anemia, low red blood cell count, let me give you an example of a disorder that can affect white blood cells, and that would be leukemia. Leukemia is a cancer of the white blood cells. Definitely not a good thing to have. Okay, we've talked about the plasma. Then we've talked about, for the formed elements, red blood cells and white blood cells, which means all that's left are platelets. The platelets will look like little darker dots. Technically, it's not really a whole cell. It's more of a cell fragment. We produce many, 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 many of them, and their function is blood clotting. When we have an injury, we activate these platelets, which later down the road form these fibrin threads to try and plug the injured area up and then trap underneath all the supplies needed for healing. Platelets, blood clotting. Put those 2 together. Speaking of blood clotting, why don't we talk about it? Of course. The fancy word for blood clotting, or the cessation of bleeding and the initiation of healing, is hemostasis. Of course, the prefix hemo means blood. This process is really important. It's easy to take it for granted. You know, if we get a tiny cut on our finger, you just keep going on with your day, don't you? We don't think anything of it because our body is usually so good at clotting. If we have a small cut and we don't have the ability to clot, then we're going to continue to bleed. So something that is small, if we don't clot properly, could actually lead to something serious. This is how much we rely on blood clotting. I prefer to talk about this process in 3 steps. You might see other books use different terms. It's always the same process. I find these terms to be the easiest to understand. So as you're studying, what do I have here? Here's the 3 phases. I'd like you to know a little bit about it. You don't have to know much, about these. Oh, know a little bit. I'm going to cross that right off. Aren't you glad you're listening to this video? Vascular spasm just means that when a cut happens, so in this picture, this was a nice normal fingertip, but there was a cut. It's my cut sound. When there's a cut, the blood vessels around it immediately vasoconstrict. And that's what vascular spasm is. The blood vessels around the injured area constrict to limit more blood loss. Then the platelets get active, and the platelets will form a plug. I mean, literally, the platelets just come in here and they fill the gap. At first, it's a temporary solution. We want to fill it in to prevent bleeding. We want to fill it in to be able to trap some of the supplies needed for repair underneath. And eventually, we get to a full blood clot, which can be known as coagulation, where now we have those fibrin threads laid down, and now we can really trap the supplies we need underneath. Know that these steps happen in this order, and a very basic understanding of what happens in each. Okay, here are some clotting disorders. You know, when we have a cut or damaged tissue, we want blood clotting. So there are many instances when we want blood clotting if you have injured tissue. But sometimes blood clotting can happen even when we don't want it. And this is a condition of a thrombosis. So if you look on the top right here, we're zoomed in on an artery. And let's say the artery wall should be this wide, and it should leave plenty of room for blood to go through. However, sometimes there can be plaque building up on the walls. So instead of there being a smooth wall with a very wide opening, there can be some plaque that begins to develop. Could be from lifestyle, poor diet, part of it could be genetic. And as this plaque builds up, it could get bigger, and it begins to impede the ability of our blood to go through. Sometimes, and this is a worst case scenario, sometimes that blood clot can break free. It can literally break off of its anchor and break free. So the fact that there's a clot forming where it shouldn't be is called a thrombosis. A clot or a thrombus. A blood clot forming where it shouldn't be. Because remember, sometimes we want blood clotting. I have an injury. Otherwise, in a regularly functioning artery, I don't want a blood clot. I want the artery to stay nice and wide open. But a clot or a thrombus can develop, and the worst case scenario is that clot breaks free, travels through the blood vessels. That's called an embolism. When a clot in a place where it shouldn't be breaks free and begins to travel through the bloodstream, that's called an embolism. And you see, that clot that is broken free is most likely to get lodged in a part where the vessels are narrower. This is why if there is an embolism, we more commonly see a pulmonary embolism, where that broken free clot is able to go circulate through most of the blood, but when it gets to the pulmonary arteries, which are narrower, which are going into the lungs, it cannot fit and it could cause a blockage. There could also be a cerebral embolism up in the brain. I did that again, didn't I? Make sure you know these two clinical measures. These will be important for someone in your shoes to know. Let's first start with oxygen. Well, no, we'll start with hematocrit. Hematocrit is, you might see it called packed red blood cell volume. Hematocrit is the percentage of the overall blood that are red blood cells. Hematocrit, percentage of the overall blood, including plasma, that are red blood cells. Usually, somewhere between 37 and 52% of all the blood is red blood cells. Remember, the red blood cells make up 99% of all of the formed elements. The formed elements themselves make up 45%, roundabout. So depending on your age, your gender, your activity level, an endurance athlete is likely to have a higher hematocrit. Okay, so hematocrit is the percentage of all the blood that is made up of red blood cells. What about oxygen saturation? Well, we know that hemoglobin is on the red blood cell. Oxygen binds the hemoglobin. Oxygen saturation means how well saturated are the hemoglobin. Each hemoglobin molecule can hold 4 oxygens. Each hemoglobin can hold 4 oxygens. If all 4, I don't like how this is, let me make it better here. If all 4 sites are taken, then that hemoglobin is said to be 100% saturated. What if only 2 of the 4 hemoglobins are saturated? That would be 50% oxygen saturated. That'd be really low. We operate at a very high normal oxygen saturation. I'm going to even say 97 to 100. 95 is even kind of low. Under normal conditions, over 95% of all of our hemoglobin are occupied by oxygen. This tells us that our red blood cells are good at transporting oxygen. Here is what a CBC looks like. If someone goes into the doctor, whether it's for a yearly physical or whether they're having some kind of issue, and a lot of times the first baseline step will be to take some blood and run a complete blood cell count. You don't need to know these, but it gives us a lot of information. You can see how many million red blood cells should be present per microliter. That fancy U thing is a microliter. You can see the normal hematocrit we discussed. You can see the platelet number should be high. White blood cell number should be low. We can even do a white blood cell differential. What are the 2 most common white blood cells? Neutrophils and lymphocytes. So these numbers can tell us a lot. You don't have to know, but this is what it would look like. Okay. You can see I'm recording this in October, so this is a very timely picture. Okay, the last part of this chapter involves blood typing. We're talking about blood, so I think we got to do it. When we talk about blood typing, we're going to be talking about the red blood cells. Oh, let me get my pen going here. We're going to be talking about the red blood cell surface because on the red blood cell surface, we can have these normal large proteins. Maybe it's only A's. Maybe it's only B's. Maybe you have both A and B antigens present. Whatever. These antigens are considered normal. You're born with them. They're not dangerous to the body. So, on our red blood cell surface, we have some antigens. They're normal. The body doesn't view them as foreign. They're just there. And actually what we're going to find out is, depending on what antigens you may have, that's going to tell us what blood type you are. But those are the antigens. We also have some antibodies, and the antibodies exist outside the cell. And typically an antibody is something that your body makes in response to exposure to something. Not all antibodies are, I'm not sure where I was going with that. Let me just back up. Okay, so antibodies would be in the plasma. They're produced in response to exposure to something. Antigens are on the surface of the red blood cell, and you kind of have them or you don't. That's it. When we talk about whether someone has A blood type, B blood type, AB blood type, or O blood type, it's all about the antigens. If a person has A antigens on their red blood cell surface, they have A blood type. If they have B antigens on the red blood cell surface, they're B blood type. And then if they're AB, if they have both, they're AB. If you have both the A antigens and the B antigens on your red blood cell surface, you're considered to be AB blood type versus, I keep thinking I'm moving it, and I'm just making more lines, versus type O, which has no antigens. So you should know this. This is how we classify a blood type, based on what antigens are present on the red blood cell surface. You can see here a chart of who can donate to who. What I do want to point out is these two at the bottom. Type O is the universal donor. Type O blood can be given to anybody. That's what makes it so valuable, especially O neg. Whereas type AB is the universal recipient. Anybody can receive type AB blood. Hold on. Let me say that again. Anyone can, O is the universal donor. Anybody can receive O blood. AB is universal recipient. AB can receive blood from anybody. Okay. Now, there's also an RH group, and this is what tells us whether a blood type is positive or negative. Basically, the RH is a grouping of another antigen. So we already talked about the A and the B antigen. If a red blood cell has the A antigen on it, A blood type. If a red blood cell has a B antigen on it, B blood type. Well, there's also another set of antigens. Notice I said set because there's many of them. There's another set of antigens called the RH antigens. Here's the deal. Either you have them or you don't. If you have the RH antigen, whatever your blood type is positive. If you don't have the RH antigen, whatever blood type you have is negative. So, let's give some examples. If someone has the A antigen on the red blood cell surface and the RH, what's their blood type? A positive. What if someone has the B antigen and nothing else? B negative. So, either you have the RH antigens or you don't. If you do have them, your blood type is positive. If you don't have them, your blood type is negative. All right, we are coming down towards the end here. I want to talk about a potential condition called erythroblastosis fetalis. Please don't automatically get scared away. I'm going to try and explain it as best I can. And the reason why I'm explaining this is because it absolutely can be fatal if we don't recognize it. This is a condition that can only happen when the mother is Rh negative and her fetus is Rh positive. Well, how would her fetus be Rh positive if she's Rh negative? The father, right? So the father could, through genetics, bring down, the father could be responsible for giving the fetus the Rh positive. Well, when this woman has the baby, there will be some mixing of blood, and the mom is going to be exposed to the Rh. As a result, the mom will form anti-Rh antibodies. This could be a problem during the second pregnancy. Now we have the same mom who is Rh negative, but she has the antibodies against Rh. Well, what if her fetus, again, is Rh positive? Now the mother has an anti-Rh antigen. And if the baby comes in with the antigens, the antibodies for that antigen will attack it and kill it. Actually, to prevent this, any woman who is Rh negative who gets pregnant will almost always be given a shot called Rogam, and that prevents her from producing these dangerous antibodies against the Rh. There I go again. Here it is, laying it out, what I just said, order for order. How to prevent it, not much of a problem in the U.S. anymore. Okay. All right, nice and easy here, I think. Stay tuned for the heart and blood vessels.